the talk I gave on Sunday. Most importantly, I wanted to show up that chronic GvHD is a continuous process starting very early in the setting of stem cell transplantation. There are several studies confirming that, for instance, T-cell depletion, which affects T-cells immediately at the time of transplantation, can reduce chronic GvHD. So there must be early events inducing chronic GvHD, and we shouldn't forget about it. The event doesn't start at 100 days or later. It starts with the procedure of transplantation. And there's very recent arguments showing this. For instance, the introduction of regulatory T-cell transplantation with the ORCA-T approach shows very clearly that you can reduce chronic GvHD to less than 5%, which is a dramatic advantage by manipulating the graft. So we never should forget it starts very early. Then, of course, how does this work? Now, I think the first step is that acute GvHD damages important organs which are relevant for immunoreconstitution and which are relevant for development of a tolerance after transplantation. And that is thymus. We have evidence that thymic damage occurs by acute graft-versus-host disease, but to get the long-term tolerance, you need an intact thymus to select the right T cells. And I also mentioned that there is not only selection of T cells in the thymus, but also selection of B cells, which are another important population in the context of chronic GvHD. And this occurs mainly in the germinal centers of the lymphatic organs, of the lymph nodes, and they are so-called follicular reticular cells, which are also important to present peripheral tissue antigens to the B cells and when they maturate. And if these follicular reticular cells are damaged again by acute GvHD and by conditioning, then the selection of B cells doesn't work. You get hyper-reactive B cells, and finally this induces production of autoantibodies and alloantibodies, which are another important mechanism in the context of chronic GvHD. This is combined with a very strong stimulation of B-cell recovery. We know that levels of BAF, which is a B-cell activating factor, are very high at day 90 after transplantation, and they predict chronic GvHD. So you have dysfunctional selection of the B cells and very high stimulation of B cells, and so you get a lot of auto and antibody producing B cells. This B cell pathway is of interest as there are many new molecules described, important in the context of graft-versus-host, chronic graft-versus-host disease, especially the ROC pathway, and this is important because ROC inhibitors are now on the way for treatment of chronic GvHD, and they show quite positive results, especially also in severe manifestations of chronic GvHD, like pulmonary chronic GvHD. So we have learned a lot about the pathophysiology on the T cell side, on the B cell side, and finally we have to consider the last step of chronic GvHD, which is after hyperinflammation, dysfunctional immunoreconstitution, the development of fibrosis. So a lot of patients with chronic GvHD have scleroderma or fibrosis of the lung or other organs. And this is the final part of the pathophysiology. It's induced by IL-17 positive T cells. They are also stimulated by this buff levels and by these follicular reticular cells. And there are also other medications like Ruxolitinib, which interfere with this pathway, but also the antibodies contribute to this fibrosis. It has been shown, for instance, that the new ROC inhibitors also reduce fibrosis in the target organs. So I think we have gained a lot of understanding in the pathophysiology of chronic GvHD. We have to think that we can only prevent it if we start very early with our intervention. So even GvH prophylaxis has to be designed with the intention to prevent chronic GvHD. There are still open questions. I also discussed them in the context of my talk. So, for instance, what determines organ specificity? Chronic GvHD is a multi-organ disease affecting eyes, mouth, skin, urogenital tract, and many other organs. And the question is, why does this happen? It could, of course, be the autoantigens from these organs. It could be that specific damage to these organs induces organ-specific chronic GvHD. There are some reports, for instance, for the eyes, that ultraviolet light damage, sun exposure contributes to a higher susceptibility. Irradiation might contribute. As my second topic was microbiota, also the role of microbiota can be discussed because eyes, mouth, urogenital tract, the lung, they are all exposed to microbiota, and it could be the interaction of the local microbiota which favors inflammation and development of chronic GvHD. But we have to learn more and to find also predictors of organ-specific chronic GvHD in order to do early and more organ-specific treatment. That was my last part of the talk, that I discussed potential biomarkers of chronic GvHD. There are some cellular biomarkers, there are buff levels, there are other chemokines which predict chronic GvHD, but unfortunately they have not the high accuracy we have currently in acute GvHD, where the magic biomarkers already can be used for identifying high-risk patients. That's what we are missing in chronic GvHD, and it's very important that we have efforts of multi-centered prospective trials to identify such biomarkers. That was the main content of my talk about chronic GvHD.